So Komfo Anokye is in the news, but Komfo Anokye's issues, we believe, is just a tip of the iceberg. Let's have the big conversation here. Let's look at the big picture. Because yes, Komfo Anokye is facing a triple-headed problem, which is one, he's now have the situation where the doctors are on strike. Two, he's on the list of the health facilities that will be disconnected and will not have electricity the next 72 hours. And then, of course, three, we've heard from the Komfo Anokye management themselves about the challenges they're currently facing in terms of the infrastructural difficulties that they have making healthcare the delivery of healthcare in that particular facility, which is the second largest referral facility in this country, serving a bigger geographic area compared to Kolebu, making that a bit of a challenge for them. But there are major issues that this throws up, this triple whammy that they're having to navigate. And that's what we want to really look at, because it opens up to a bigger conversation, even far beyond what you see when the ECG says you're going to disconnect these facilities in 72 hours. If you look at it in a bigger picture, in a bigger sense, you begin to see a bigger problem. And we need to stop for a second and talk about this. We're talking about 91 health facilities across the country, owing a total of 261 million. So just imagine a health facility without electricity. The ECG is doing what they must do, which is they must rake in revenue, because if they don't have the revenues, the entire value chain when it comes to the energy sector will collapse, which is why you see erratic power supply. So they must go after the monies. And if indeed the hospitals owe them, the argument is that you must disconnect them or they must pay to avoid that. So 91 is quite a significant number indeed. 261 million cedis is also very, very huge. And so ECG is going after them. And you begin to break down, you begin to see the extent of the problem. We're talking about the Kolebu Teaching Hospital, our biggest referral facility indeed, the premier hospital owing ECG 10.2 million cedis. You look at the Komfo Anokye Teaching Hospital itself, 27.3 million. And then you look at our military hospital, 37 military hospital, a whopping 33.5 million. How did they come by accumulating, how did they accumulate this huge sums? Rate Hospital, 41.6 million. Electricity that they've used that they didn't pay. And you must look at how important electricity is to the hospitals. In fact, I argue it is possibly the most important input for a hospital. You can have all the latest equipment, all the latest life-saving equipment you can find, the most modern, cutting-edge technology in the hospitals. If you don't have electricity, it's of no use. People will die. And so this is important for them. And so if you are evaluating the importance of electricity to the hospitals, why aren't they prioritizing the payment of electricity bills then? Because it's a primary input without which the hospital cannot simply function. So that's a bigger question that we need to ask. What is it about the structure of our public health facilities that allows them to accumulate this much? And how do you deal with that fundamentally? Not just papering over the cracks and negotiating some settlement arrangement that will only lead to further accumulation of debt that will just come back to bite down the line. So something fundamentally must change. And hopefully tonight we can get to have that bigger conversation. Because if you look at that, national picture at the regional level, Greater Accra alone, the public health facilities owing the ECG, if you put that together, 130 million. It's just not sustainable. Something must change. Something must give. What must give? The argument is what we are talking about with the ECG is symptomatic of a bigger problem. And that is why we need to have this particular conversation. Because if you look at the health facilities, right, and their internally generated fund, you're raking in some fair bit of money into their IGF accounts. Why is this important? It is important because the figure that I showed you already, the hospitals must pay with their internally generated funds. There are three sources of funding for these public health facilities: the government, donor, and IGF. Three. We will see a graph that will tell you that over the period, the donors' funding is now very negligible. We are left with government funding and the IGF. The IGF is purposely for catering for goods and services. Electricity is part of that. So the amount I've shown you, they will have to dig into the IGF to make that payment. So let's ask the question, have they made enough to pay for electricity and everything else that they need in the facilities across the country, including the consumables, for which reason, as you know, a whole Kolebu Teaching Hospital had to close its renal unit because they could not invest in the dialysis machines that they should have been investing using their internally generated funds. And so that in itself is already a problem, right? So if you look at that period between January to September, the Korle Bu Teaching Hospital brought in IGF of 112.2 million cedis. How much do they owe to the ECG? 10 million. So it's simplistic to say, well, I mean, if you make 112 million, then you should simply be able to pay 10 million to the ECG, because that will leave you still over 100 million cedis to do everything else in your facility, because government will take care of the salaries, right? And so you should have that. Is it that simple? Well, we'll try and dig into that. Let's come to Komfo Anokye, because that is obviously a test case. It's a case study for tonight. They made, within the same period, January to September, 83.3 million. And this really is according to the Finance Ministry in terms of IGF. So they must take that 27 million cedis from this 83 million and pay Electricity Company of Ghana. So what is the problem? If you have 83 million, you should pay 27 million to the ECG. But why haven't they done so? We'll hear from them themselves, because you begin to understand when you begin to drill down a conversation that is far more complex than looking at the numbers and saying that they have the money to pay. Because what about the consumables? What about other things that they need to get to run the facility to save lives? But of course, they are not forcing the hospitals to choose between buying consumables that will save life and keeping your lights on. Both very essential. So how do you make these health facilities financially sustainable is a big question that we need to try and answer tonight. So that is a story with internally generated funds. If you drill down again, and we like to do that because it gives you a sense of what is possible, we've drilled down to what we know when it comes to the IGF. When we're asking the question for Komfo Anokye Teaching Hospital, knowing how much they've raked in over the period from last year, they are making 234,000 cedis a day. For a week, they're making 1.6 million cedis in a week and 7 million cedis in a month. So they pay the electricity bills on a monthly basis. So how much of the 7 million is going to electricity on a monthly basis? So they remain current. Do they even have a plan for that? And does the structures that we currently have allow that to happen? But then I was telling you about the funding sources for healthcare delivery in this country. The three main ones, you want to even add the ABFA also in there, which is in essence still government, but donor is virtually negligible. It's virtually gone now. The donors have done very little by the period, and it's been draining on the downward decline for obvious reasons we should take care of ourselves, obviously. GOG is the biggest source of funding. But then the next biggest is IGF, which is what you see as of 2020. The last time data was available for this. And I'm pretty sure we can get the 2023 one too once we dig a bit more and get the updated reports. But this is what we have as of the latest, right? So you begin to see here the IGF component. So increasingly over time, government is having to bear a bit more, but the significant growth in terms of funding sources has come in from IGF, which means the hospitals are currently being asked to do far more to carry their own weight. And we'll hear from Komfo Anokye. They were told July last year by the government that we're no longer going to pay your electricity bills for you. You need to pay yourself. So that is the reason why you begin to see that growing. And if you add in 2023, you possibly will see this grow even further. So going forward, it appears that we are moving towards a situation where the hospitals will have to be financially self-sustaining, right? We are not there yet. How do we get there is a key question to ask here. Now, so it is also part of the reason why the doctors are on strike, I must argue. Because why are they on strike in Komfo Anokye Teaching Hospital? Because of a lack of accommodation, right? And if you have enough money, you will definitely provide the facilities that will suit your workers, that where they can sleep so they can work. Less money means less available to provide the facilities, including accommodation for your workers. And the reason why the doctors say, if you don't have any place to sleep, but even where we currently sleep, a private developer says they want to build there. They want to develop that particular land on the back of a court order. So leave. That's the doctor's argument. The regional minister disputes that, by the way. But that's why they've laid down their tools. They say, well, we are going to look for accommodation, so we can't work. Today, people were left stranded. Patients were left stranded in Komfo Anokye Teaching Hospital. But it all adds up. Everything I've said up until this slide adds up to to the problem Komfo Anokye is facing with the accommodation, for which reason the doctors say they have no place to stay, their lives are being threatened, electricity has been cut because the private developer wants to develop and they want to leave work to go and look for accommodation, right? If they have enough money, they would have built hospital accommodation facilities for these workers. So that it adds up. So they say they want to go on strike there, and they have done so, which is another issue. As we know, at least 20 doctors have laid down their tools. Other CAT workers are threatening to join. Doctors from other hospitals now also telling us that they will also want to possibly join in solidarity. So you see how this snowballs into a bigger problem. And look at the numbers of patients who are likely to be affected here. The OPD cases coming in, if you're already a patient on the ward, you'll be taken care of. But they were not today taking in new patients coming in. A daily number of 1,093 patients coming into Komfo Anokye Teaching Hospital on a daily basis will have to be turned away because of the problem I'm talking about. So, and the bigger number here, we're talking about in a year of 393,000. So this is critical. This is life-saving, and yet they've laid out their tools for all the complicated reasons that I've illustrated. GMA is saying they may have to embark on a nationwide strike in solidarity. So I believe this is a bigger problem. It's symptomatic of a wider challenge. Let's have that conversation now, and I have the guests to do just that. After the break, I'll introduce them, and then we can drill down to the facts. But we must hear from the ECG already, and so that they can give us a sense of where we are tonight in negotiating an outcome, or are they still going to go ahead and disconnect? Once we have that clarity, we will now drill down to why this has become an issue that we are talking about right now, and how do you sustainably over the period ensure that we don't get back to this point where ECG 7 demand notices, giving hospitals 72 hours to pay up or get disconnected. Details after the break. And PMS is always brought to you by Syntex Tanks. It is strong, it is tough. Alomo Bitters experience greatness in every moment. Ghana AIDS Commission and Pepsodent, every smile matters. And Syntex Tanks is the tank I recommend to you every evening because they have bespoke offerings for you. You can choose any size you want, any color. They are also nationwide. They have a 7 years warranty. You can call them wherever you are and they will deliver it to your doorstep. Just pick up your phone and do so. 0244 335 168 or shop online at syntexgh.com. Syntex Tanks, are you strong, are you tough? Pepsodent Cavity Fighter toothpaste is also one that you need to pick up tomorrow morning. In fact, before you sleep, to brush your teeth, because they have a perfluoride and they make sure that your cavities are sealed. They have the Pepsodent Cavity Fighter, comes in several packs, 175G, all the way down to 12G. You know what that means? You can always get what you can afford at any time. Pepsodent, every smile matters. My guest joining me for a conversation tonight on this big subject is Isaac Ofeba. He speaks for the Health Ministry. Dr. Richard Salome is the General Secretary of the Ghana Medical Association. Kwame Frimpong is the spokesperson for the Komfo Anokye Teaching Hospital. And Kwame Sapon-Asiedu is a pharmacist and fellow in health with the CDD. Grace Gashon is the communications manager at ECG, and I wanted some clarity from her before we start tonight. And when she joins me, we'll get that clarity. We also need some clarity from the Komfo Anokye Teaching Hospital PRO if he's on right now. I'll wait to get them on to get me the clarity on where we are as of tonight. But before we hear that, I want to bring in very quickly the spokesperson for the Health Ministry, who is joining us right now for a conversation. And I wonder, at the Health Ministry, have you been briefed on the challenges with the hospitals when it comes to the debt they've accumulated to the ECG? I know today there have been meetings to try and resolve this. Has the Health Ministry been involved in it? I can't hear you. If you may unmute for me.
So, Evans, good evening, and good evening to cherished viewers. The ministry had been informed about the challenges regarding the disconnection of our hospitals, and a lot of discussion had gone on to ensure that the disconnection is avoided. You and I know the challenges that the country will face if we should allow this to happen, and so The ministry is highly involved in negotiations, especially coordinating the hospitals to ensure that amounts are raised for payment of such arrears that are likely to be dependent on the disconnection.
Grace Gashon is a communications manager at ECG. She joins us with a quick input. Grace, where are we tonight with the negotiations over this? Have you even sat with the hospitals in question, the health ministry, to try and find a solution to this? Or you're going ahead with the demand notices and the 74-hour deadline?
Yeah, good evening, Ivan. Most of the hospitals received their final demand notice today. And after receiving the demand notice, they have 72 hours to pay the debt. So we will not do the disconnection tomorrow. Neither did we do it today. We are waiting for the 72 hours, and we hope that by then they might have spoken to us and we'll find a solution to it. We don't just want to disconnect them. We want our money to be paid.
You speak tonight, it's your expectation that a conversation will be had tomorrow to avert a disconnection?
Yes.
Please say that again.
Or they will pay the debt so that they will not be connected.
But you have served the demand notices on all 91 hospitals?
Yes. No, not all. Tomorrow morning, those very far will receive the.
Okay, good.
Uh-huh.
Okay, and I want some clarity from ECG itself. In the past, what has been the practice when it comes to billing the hospitals?
Well, what for some years now, pay their or their own.
Hello, Grace.
Hello, can you hear me?
I can hear you now. Yes, you. What did you say again?
I'm saying that what I know is for some years now, the hospitals pay their debt or their bills on their own.
They pay it on their own. Okay.
Yes.
Okay.
That's what they're saying now.
And have they always remained current?
Have they always remained
current? Have they? Yes. Have they always kept to the? No. They haven't.
That is why we've got to see.
Because
and we don't disconnect from current bills.
You don't disconnect?
From current bills. Let's say we don't disconnect for the bills that we received in February. We are in March. March bills are yet to be distributed or yet to be received. We are not going to disconnect you on the current one, which is February. It's the accumulated one where we connect you on.
Okay, because I see the figures out there, and some of them have accumulated more than 40 million. Why did the ECG wait till now for a hospital to accumulate 40 million CDs in debt before you give them demand notices?
I tell you that, like I said, it's not caring. It's accumulated. They pay some and then some left. And what we forget is that when you pay, let's say you have a 10,000 and you pay 5,000, the remaining 5,000 is there, plus what you are currently using. And it adds up and it becomes more. So it's not like we left them and they accumulated this month. We've been talking to them, some have been paid in this. They don't clear whatever they receive for the month inside.
Okay, and thank you very much, Grace. And so tomorrow, the rest of the notices will go out. And you're saying that if they don't negotiate a setting, because you're willing for them to entertain, you're willing to entertain a payment schedule. You're not saying pay all now. If they have a conversation with you, you can spread it over time.
We are hoping that they will pay at least up to 70% so that we avoid disconnection. Okay,
so if they don't do that, you would go ahead and disconnect?
After the 72 hours.
Then you disconnect 72 hours. Thank you very much. So they must pay 70% or they get disconnected. Kwame Frimpong speaks to the Komfo Anokye Teaching Hospital. They have received their demand notice, you told us earlier. But Kwame, where we stand tonight, I'm curious. Have you begun the conversation yet with the ECG on how to resolve this matter before a disconnection in 72 hours?
Perhaps the issuance of is produced by ECG, we have been engaging them because at our end we had a peculiar problem where the nursing and midwifery training college is on the same feeder line, it's on the same line as the hospital. So we weren't sure the bills that we were getting also considered past the energy cost of the training college. We had accused them to separate the two institutions so that we will know exactly how much is attributed to us. Unfortunately, we've been trying for some time now, and that request has not been included. And so what we've been doing is to pay some monthly money just to indicate to you that we have prepared to pay at the part of our bills, and we need to know exactly what we are preparing. As at the moment, the electrical wiring system of the two institutions said that they are joined, and so we are not in a position to establish clearly what our indebtedness is to ECG.
Okay, apologies that we're just having a challenge there with the issues
Hello.
with the hearing here and the technical audio here. But I want to quickly bring in my colleagues who are my guests who are joining us on Zoom right now whilst trying to fix that because I can't hear him speak through the microphones here. But Kwame Sopanasiru, this challenge, as I've just been saying, do you agree that it goes way beyond the hospitals accumulating debt? That is symptomatic of a bigger challenge?
Evans, and good evening to listeners and my colleagues. I totally agree. The point is, in this country, we like creating problems. And sometimes I just think we like creating problems. You need to go back to the genesis of this problem, where in July, when it was announced that the hospitals had to pay for their utilities, and ask yourself, if you remember, after that was when the thought leadership program for the renal dialysis units was held by Joy, and I gave the introduction, and I did say that the way the IGFs were structured for all the hospitals didn't give them room for them to have enough money to pay for other things, because they were hardly breaking even for the services that were generating the IGFs. And I did remind people on that program that all the hospitals have to go to Parliament to be able to get their fees approved. And when Parliament approves their fees, it doesn't include the utilities they use to run it. It barely cuts enough to pay for the reagents and other things that they have to procure to run these services. And that was the brouhaha that started the renal dialysis issue, because Kolebu was saying that they were struggling and they were indebted. So to then think that because money is coming in, these hospitals could pay for their utilities and then build them was only kicking the issue down the long grass and was a time bomb. It was a problem waiting to happen. So I am not surprised that the hospitals have accumulated this amount of debt. And that is why I say that I totally agree with you that this was a problem that was self-inflicted. There were only two options. It was either the hospitals were going to be made to charge for the true cost of their services, like the private hospitals charge, or the government was going to subsidize them. There was no halfway house. The government opted for a halfway house, and now we find ourselves in an IMF bailout where they are saying that the ECG should be able to stand on its feet. The ECG is then trying to get all its money. We saw them go to Parliament. They are going everywhere, to private households, to private companies and all that. And now they are going to the hospitals. And so basically, I was trying to model a scenario today. Now, let's say you are an ECG worker, a technician who's been sent to a hospital because the hospital has defaulted and can't pay their bills. And you have to go and disconnect them. And after disconnecting them, as you're coming down your hoist, you get a heart attack. What do? It seems that we create problems and then we end up cutting our nose to spite our faces. And it's become the game in turn. And for me, that is what needs to be resolved. I think we're starting the resolution from the wrong place where the ECD are saying we've served notice and they have to pay. If they don't pay and they don't come to an amicable negotiation, we are going to cut them off. And the hospital saying we cannot pay, or like Komfo Anokye is saying we are sharing it with the NTC. We are not dealing with the root cause of the problem, which is the hospitals, based on their tariff structure, are incapable for paying for their utilities. And that is the bigger conversation we have to have as to whether we are prepared for them to charge the true value of the services they provide to be able to pay for these utilities. Because we have to remember, the IGFs are based on specific services.
Yeah.
It doesn't include things like the electricity or water that is consumed in the wards where people are staying and all other things. So if the hospitals have to charge the true value, they've got to have a build-up cost of all they produce in those hospitals and then put it on the facilities or services they provide that generate the IGFs to come up with a true value. And Parliament will just have to agree to them charging this, which the citizens would not be able to pay. So we need to have the bigger, honest conversation and understand what we want to do as a nation. This firefighting is not going to solve the problem.
And thankfully, I have the GMA Secretary with me. Dr. Salome, do you agree with that? That this is actually an opportunity to have a serious, painful conversation about the tariff structure for public health facilities?
Yes, good evening to your listeners. And Evans, I think the last time we had this discussion about facilities, maintenance issues, I raised this issue. Often, just as Kwame is saying, often we approach the issue sometimes from the wrong end. This issue about having discussions with ECG saying you should come and sit down with them and talk, is neither here nor there. We will come back to this same issue one way or the other. We have to be clear in our minds. Last year's directive came in the middle of the year. Remember, hospitals would have budgeted, presented their budgets, have been approved already, without having knowing that they were going to add paying of electricity tariffs to that. Then this comes mid-year when people have essentially consolidated their budgets with all the assumptions that are necessary. And then now this comes in that hospitals will have to pay. I have done a check with many of the 91 facilities that have been listed, and I just called a facility in one of the strongholds of this current party, and probably in the president's own hometown. And they spent close to 160,000 cedis out of their 180 to 200,000 cedis IGF on electricity bills alone. So if you on consumption, so you're only left with 40,000 cedis to pay the staff who are on IGF, to do maintenance work, to buy the consumables. It is not sustainable. I have called a regional hospital in a similar vein, which is spending 300 to 600,000 cedis on a month-to-month basis. Now they have even got other equipment which is going to even spike that up. Let's not forget also that the tariffs are going up. I mean, we had big increases in the tariffs, which have increased the consumption in terms of the cost to the facilities without any commensurate increment in the tariffs. So I think it's point on that we need to have a clear conversation on this matter to have sustainable financing of power to facilities, as well as maintenance of facilities and other related matters, which often these tariffs do not cover, especially knowing NHIS is our largest single financing for healthcare in the country. So we need to have that clear discussion. And health being a public good, government cannot shirk its responsibility and shift that to facilities. Knowing also that the tax that we take, NHIL, has been capped. So the rest of that money should be channeled to some of these. So I think that it is Kwame spot on, and it's the same observation we have also made, knowing that there are challenges with the country, but then we must ensure the healthcare being a public good is sustained. Well, yeah. We have to look at ways forward, maybe as we discuss.
And thankfully, Kwame Frimpong, who speaks for the Catholics here, I want to understand what really happened last year. And Kwame Frimpong, so in July, when you were told that government will no longer pay the electricity bills, was there an alternative provided? Were you giving room to add that to your billing of patients, for example?
No, as it has already been pointed out to you, in the healthcare financial architecture of this country, there are certain expenditures that are deemed to be paid by the state. For instance, HR salaries, capital expenditure. Those things, when your tariffs are being considered, those components are taken out. And for years, decades, because the government was paying for electricity bills of the various hospitals, it was never considered as part of our tariff build-up. And so, as I indicated earlier in the day when you spoke to me, we've been trying to have some conversations with the ministry as to the deploy and getting a revenue stream that will cater for the energy costs that we are now doing. To be frank with you, our IGFs are already under pressure. You gave a long list of the revenue streams of the various hospitals.
Yes.
Part of the expenditure.
Yeah.
But in healthcare, every revenue is expenditure dependent. There's no in the healthcare sector that does not, it's not as a result of a direct expenditure that you've made. And healthcare is one of the most expensive industries in the world. And so, any other additional position in the authority structure is extremely difficult for the hospitals to do. That's why you see all these hospitals finished with the ECG. And therefore, they need for a bigger conversation as to how this additional burden that is being transferred upon the hospitals can be treated for. Other than that, it is truly difficult for the public hospitals to bear this huge cost.
Yeah, and also I need clarity. The amount, for example, that you owe of 27 million, I know you the issue that you talked about, that the meter you share with the nurses and midwifery college, for example, is an issue. But if you take that aside, did you accumulate all that since July, or you also have legacy debt in that?
I'll have to check with the finance department. What I was told was that we have been accumulating in the region of 1.2, 1.3 on monthly basis. So if you add everything up, is I think close to how many months now? It's not even a year.
No,
so it's not even a year now. So I wonder if 3 million got accumulated from July of last year.
And our own estimation suggests that the government itself, when government was taking care of this bill, may not have paid as they were supposed to. And so now that this burden has been shifted onto you, you're having to pay the legacy as well, which is really why you're seeing those huge bills for the hospitals. Because how, for example, do you see a Ridge hospital, for example, the Accra Ridge Down Hospital, with 40 million, not the same size as Kolebu, but Kolebu is 10 million. Something doesn't add up there. Now, let's come to the health ministry. So, Isaac Ofeba, when this policy shift happened in July last year, it was obvious, was it not, that the hospitals could not carry that burden, and that to be more sustainable, the tariff structure had to change. Was that even thought of at the time that we were making the shift in policy? Hello, Isaac Ofeba.
So, can you hear me?
I can, yes.
Yes. So before the shift of the policies, payment of bills to the hospitals, government had paid a number of bills for those same hospitals. We are talking about over 400 million Ghana cedi debt that was being incurred at the time that government have lifted and paid before they were asked to start payment by themselves. Now, what the ministry did was to write for separation of meters at the various facilities. We realized that there are some of the facilities that are sharing consumption with some other facilities that could be able to pay for themselves. And we believe that it's also accumulating to some of these high billing that the hospitals are going through now. And so the ministry wrote to Ministry of Energy for separation of meters, so that when we separated the clinical consumptions from some of the facilities that could be able to pay for themselves, we would be able to talk about the actual amount of money that a hospital should be able or should be billed with at the end of the month. Then we will be able to look at how possible, whether to allow them to continue to pay for themselves or government will have to leave that up. And so it's rather unfortunate that up to now we have some debts that we have to pay, and if we don't pay, we're going to be disconnected. And as we speak, the ministry is engaging both government, the hospitals, and the Electricity Company of Ghana to ensure that this is avoided, so that we are not being disconnected.
I mean, from the reality is, from the numbers that I've just put out at the beginning, it doesn't appear to me that the hospitals can pay. I mean, don't let me speak for them. Kwame with Komfo Anokye, can you pay 27 million cedis? Because the ECG says they want you to pay at least 70% of that. Can you pay that in 72 hours?
For us to pay.
Forgive me, I didn't hear what you said at the beginning. Can you pay?
We are not in a position to pay. We can't.
Okay. And why can't you?
Basically because we don't have any revenue stream for that expenditure.
Simple. It's basic. I don't get it.
Okay. Is it Kwame Sapmasud I'm here or Salome in the background?
It's me.
Yes, I mean.
Okay. Yeah, both of you can have a bite at that. Kwame Sapmasud first. Yes.
Fortunately, Evans, I think this is a simple matter. Even if most hospitals received all their backlog of payments from LHIA, put everything together, they cannot pay. And we must call a spade a spade. These gimmicks will not change anything. The matter is simple, and I have a challenge with what Mr. Ofeba is saying. That thought should have gone in before that directive should have come to facilities. And a clear, sustainable way of paying for these things put in place. If you had somebody who didn't think about patients, the person will tell you, look, come and cut the lines off. And let what comes come. Because those decisions should have been taken and discussions had with all the key stakeholders, the Ministry of Energy, the ECG, the VRA, the NETCO, in all these places where power is supplied. That discussion should have been had and a clear payment plan put in place, which makes the facilities sustainable and at the same time allows them to be able to pay. They have run various programs, for example, solar and all these things. How many of these have been situated in hospitals to allow them to begin to cut back on their dependence on the national grid? So I think we are shifting blame onto facility managers. Some of these facility managers are already being chased by drug suppliers.
Dr. Salome? Did we lose him there? Kwame Sapmasud, please. Okay.
Consumer, and I think that's right. We must do the right things. And I think ECG itself must also tarry carefully, because out of the total indebtedness that they have, healthcare only contributes 4.5% of this. This is 261 over the 5.7 billion or something that they are owed. Why do you want to start from the healthcare? Why do you want to start from here when there are bigger chunks waiting? This is just the coins on top of the 5 billion. They need to be realistic. The facilities cannot pay this within the 3 days that they are saying. And if they are going to actually disconnect, then they will have to disconnect all the facilities, and we'll all sit and wait and watch what government does. But I think they must move away from that 72-hour ultimatum and have realistic discussions, so that we all come around the table, have an agreement, let the people of the nation know that healthcare is expensive. If government cannot bear the cost, let government be honest enough to admit that, and let people know that they must share part of the cost. Or if the capping of the NHIA finances can be brought back so that the full amount is sent to NHIA and all this factored into the costing structure of the tariffs, then that should be done. But the 72 hours, I think, is unreasonable, and it is not going to be adhered to by anybody. And I don't believe they will cut anybody's power. If they do cut the power, well, we will all wait and see the consequences of it.
Kwame Prasiru, so what is the best model to make the hospitals financially self-sustainable?
Well, the best model is simple. The best model is to build a consolidated payment structure where the hospitals would have to put together all what goes into running. Because the government is basically telling them you cannot pay, so you've got to pay. And they have to also respond to the billing requirements of the ECG. So they need to look at how much are we expected to pay to this ECG? How much are we generating? How much of it must be increased? And they have to go to Parliament with a full complement. The only problem they have when it comes there is that because with the IMF program, the electricity tariffs can be adjusted every 3 months. What it means for you and I, Evans, is that every 3 months, if we use such a modeling, then your health cost for some of these services is going to go up or down, which also doesn't allow the individual patient to plan, because a lot of these services that generate the IGF are actually not covered by the NHIS. You see, so when you go to things like cancer care, renal dialysis, a lot of those things are not covered by the NHIS. The things that generate the bulk of them, and those are for those hospitals loss leaders anyway, because that was what drove the hospitals to say they wanted to increase the tariffs for renal dialysis. And so, and that's why I say this country, we like creating problems, and that is why I agree with Richard when he says he has a problem with Mr. Ofeba's statement. It's like when I listen to what Mr. Ofeba said, it's like the Ministry of Health didn't think through the decision, and the Ministry of Finance went along with it, or whether the Ministry of Finance imposed it on the Ministry of Health and they just took the two clients. You are not too sure where the blame lies. But the truth of the matter is the hospital's tariffs were not structured to generate these monies, because at the end of the day, the users of the service, which are you and me, are not paying for the utilities. They are paying for the reagents, they are paying for the basics, but they are not paying for the water and electricity that is used to provide these services for them. Suddenly, the hospitals are being told, you've got to cough out from that same money, and Parliament is saying, no, if we approve your new rates, the citizens can pay. So what are you telling the hospitals? You are tying their hands behind their back, and the ECG is also backing up. And you hear Richard saying, oh, it's about 4.5%, and he doesn't understand why the ECG would go after that. I understand why the ECG would go after that. Because at the end of the day, health is a public service good, and health affects everybody. The minute you cut off a hospital, you've cut off the morgue, you've cut off the operating theater, you've cut off the renal dialysis unit, you've cut off the cancer unit, you've cut off the pediatric NICU. It would affect everybody one way or the other. Like you said in Akan, Ankawa, Ebekawoba, Ankaoba, Ebekawofa. So they are targeting something that would bring the entire nation to the negotiation table, because they are also being pressured by the IMF and by all of us saying there's doomsaw, there's no doomsaw, it's partial doomsaw, it's doom preferred, doom CC. They are under pressure because they are being told they are not recouping the revenue to pay the IPPs and the power generators. What do you expect them to do? They need to ensure that we all are put under pressure. So though Richard is looking at it strictly from a health standpoint, and ideally as a health person and a researcher in the area I'm looking at it as a pragmatist and say, if I was the boss of the ECG, what would I do? I would take the route that would bring every Ghanaian, including the president, because if the president fell ill tomorrow and the hospitals that he would access have a generational or power challenge, he would suffer. The vice president would suffer. The speaker would suffer. MPs would suffer. So we are all talking about it now. Congratulations to the ECG.
Well,
it might be a painful pill to take, but I think it is, on a chessboard, would say, a strategic checkmate.
Yeah, and Kwame, the painful thing though is while this is happening, you know what we do? We'll have this conversation about disconnect, not disconnect, and we'll find a negotiated outcome, and then we'll move on. But the fundamental issues will not be addressed. And if only we can take advantage of this crisis, if only, then you will be right.
Yeah, well, if we don't take advantage of this crisis, then we're a very naive country.
Yeah.
Because you know what? Healthcare underpins the economic development of every country. There are three things that underpin economic development: health, education, and social attainment. If you miss out on any of them, your society is doomed.
Yeah.
The research is there to prove it. So if we, talking about this, and have a parliament that cannot nail people like the bosses of Mr. Fairbairn's feet to the fire and nail the ECG bosses' feet to the fire and get it solved. Because at the end of the day, yes, I can see Mr. Fairbairn smiling, but the truth of the matter is, we are all sitting on here. If he collapsed tomorrow morning and there's no electricity, he would also bear the brunt.
Yeah.
So I don't think he's happy about this situation.
Yeah, absolutely. Let me quickly get his thoughts on very briefly. Mr. Fairbairn, so fundamentally, we need to first avert the crisis of the hospitals, 91 of them going off the ECG. And then secondly, you need to address the fundamental point of the billing structure, the long-term model that it makes it sustainable. What is the ministry doing on this?
Before I move on that, I want to, for the purposes of the records, there were a number of stakeholders engagements with Electricity Company of Ghana as far back April 2023. Now, at the meeting, it was agreed that some institutions should be separated from the mother hospitals, and so we should apply to the Ministry of Energy, which we did. As far back May 5th, 2023. Then we submitted the accumulated bill, which is the bill that was already in the system, to the Ministry of Finance as far back 9th June 2023. And so a number of interventions have been done already. A number of measures have been put in place before it was lifted up for the hospitals themselves to start paying. And so one issue that I think is also accumulating to this high billing system that we have as a country is what my brother at Komfo Anokye Teaching Hospital is saying, that you have some institutions within the teaching hospital especially, whose consumption are always on the clinical consumption.
And they've made that point, but because of time, very bullet for me, we need to solve the problem, right? They've said they cannot pay the 70%. They've told you directly.
What is
the health ministry going to do about it?
Currently, there is a negotiation between the Ministry of Finance, the teaching hospitals, and the Electricity Company of Ghana to see how best we can address this current issue and put measures in place to ensure that we avoid such situation.
Okay.
It's not only this time, but going forward, we don't need to get here. And so there is a lasting solution that needs to be taken.
Which one? What lasting solution? Bullet it for me. What is it that we are going to do to avert this?
Talking about lasting solution, we need to look at whether the hospital can sustain the payment of this billing system, and if they cannot sustain, how government can come in to assist them. Okay. And if government were coming to assist them, how is that modality going to be like?
Okay, and because of time, we'd have drilled down a bit more to specifics. But Rachel Salome, just before we wrap up, I need to hear you on the strike of your members at CAF. And this is very brief, because this is all making sense, right? It adds up. No accommodation, because obviously the hospital is not generated enough to provide the facilities for them to stay in. What is the GMA's position on that challenge, though? Very briefly.
Well, as an association, we completely detest the inhumane treatment of our colleagues who are housed in those properties. And my president made the point that if that behavior continues, we would be forced to take certain drastic actions in solidarity with our colleagues. We understand clearly that the land there has been given to some private developers. However, discussions were clear that alternate places of abode close to the facility. Some of these consultants stay in the facility late. Some of them have to move to address emergencies. And that is why you realize that they were housed in a certain enclave. So if you haven't provided that and then you give a notice to people to move within a week, that is very disrespectful of their long service to the facility. And
they met them today. Did they met them today? What can you tell us? Has they been resolved?
It hasn't been resolved. Certain discussions are going on. We are watching very closely. And if those issues don't get resolved properly, then we will advise ourselves where it's necessary. And coming in the time where people are leaving the country in droves, we are even losing consultants to developed countries, having challenges where sometimes cases that we could have treated here are having to be referred outside because some of these people are leaving the country. I think this is a wrong timing, and that should not be allowed to happen again, please.
Okay, thank you, Richard Salome. Thank you, all of you, for joining me. A big conversation indeed. We're going to watch how this unfolds tomorrow. Enjoy the rest of the evening.